bring our meeting together. I'd like to welcome everyone to the Mississippi State Board of Health quarterly meeting. I appreciate the service of all of the members here who are committed to the lives of Mississippi citizens. I also appreciate the presence of Chairman Sam Creekmore, who has done so much to the state and serves in an outstanding manner in our legislature as a champion of public health. Glad he is here. The first item on the agenda is an opening prayer. Dr. Cheney, you can give a great opening prayer. Would you mind opening us up with a prayer? If everyone would please stand.
All right, let's pray. Lord, just thank you for the day that you've given us and this time that we can come together and we are so thankful that we can serve the people of Mississippi and certainly our thoughts and prayers go out to the people who have lost their lives in the recent flooding and just pray that you would just be with them and their families. And I do pray for the people of Mississippi that you would allow us to serve and just help us make good decisions that will be a benefit. We just pray these things. Right.
Now for the Pledge of Allegiance while you're still standing. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. You may be seated. First item on the agenda is the approval of minutes. There is a correction on the minutes. We need to amend the minutes of July 2024 Board of Health meeting to correct the placement of the 2% salary progression vote. The action was reported under new business, but it should have been reported as a board action item. This action was verified by a review of the recorded meeting. So this is something we voted on last year, but to be in line, I guess it is what
It's a requirement, state personnel board.
All right. So the personnel board felt like our wording was not exactly perfect. Although when we looked at the minutes, I think our wording was perfect, but we need to just have it in the minutes as corrected. So the correction will be reflected in July 2024 minutes and will state the board voted to approve a 2% progression salary increase for all MSDH staff, inclusive of the state health officer. This will be recorded under new business. A motion and a second is needed for this correction.
I so move.
Thank you, Dr. Anthony. It's good to hear your voice. Do I have a second? A second. Is there any further discussion about the approval of the minutes and also the approval of this correction? All in favor say aye.
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 Any opposed? I did want to mention Dr. Anthony and Mr. Perry have been reappointed to the Board of Health. And Dr. Anthony, which is very.
Yes, I'm very pleased at that appointment. I received a call from the governor's office asking did I want to be reappointed. And I think this is a great board. We have great leadership, and I'm glad to be a part of it.
Well, you have been a part of it since 2007, when the board was in 2007. Elaine was part of that original board and has served since then. And she has always been focused on the best interests of this state. She has been an outstanding member of the Board of Health. And Elaine, I just wanted to say publicly how much I appreciate your service over that period and how consequential your leadership has been. And thank you.
Well, thank you so much. I really guard your leadership. And I want to know that you're going to be there as well.
Well, I'm looking forward to working with you.
Okay, thank you.
All right. Next item on the agenda, we've approved the minutes.
We approved April meeting.
Oh, all right. So apparently we need to do these in two separate items. So that was the July 2024 correction. the minutes from the April 9th, 2025 meeting. Also need a motion. Elaine, would you motion to approve the April minutes?
Good. Yes, indeed.
All right, do I have a second? All right, any discussion or corrections with the April minutes? If not, all in favor say aye.
Aye.
Any opposed? All right, we are up to Dr. Edney's State Health Officer's report. We look forward to hearing from you.
Thank you, Mr. Chairman. Thank you, Board of Health members. We appreciate you being with us and all that you do for this agency and the work of this agency. And we are just so pleased and proud to work together with you. And the importance of our relationship cannot be overstated. I want to bring to your attention that this year represents 148 years of service to the state of Mississippi in terms of formal public health. With this board dating back to 1877, it dawned on me that in 2 years we have a big milestone with our 150th. If you look at the history wall, you'll see that actually the roots go back to 1799 with work in Natchez in the territorial days. And really as you know, Mr. Chairman, the Board of Health work came out of all of that, yellow fever work and the legislature recognizing that there was a need for a formal response of the state. So Alabama claims to be 2 years older than us, but I remind them we go back to 1799. So we have them by a little bit. It's also a milestone for me. August the 1st will be the 3-year mark for me in service to you and the people of Mississippi, and that will be halfway through my term. I think we have accomplished a great deal and still have a lot to do together. And as I was reflecting over, really these last 3 years to report to you, really just focusing on the challenges before us, the successes that we all have enjoyed together, and then the opportunities that remain before us for really good work for us all to partner with, together. Those challenges are constantly changing. I have learned very quickly. My first year, I was praying, asking the Lord for there not to be a crisis today, and I had to learn to change that prayer to, Lord, would you make the crisis before 3 o'clock? And the crises continue to come and they continue to change and evolve, but that is, the nature of our work, and y'all understand that. So as we are looking at the biggest challenge facing us being the cut in federal funds, we understand that the federal funding changes are not going to cause us to fail. We just will have to adjust as we typically do, make course corrections, and just thankfully we've been working the last 3 years of reducing our federal dependency rate from 80% 3 years ago to 6 months ago. I had it calculated, we were down to about 65% of our budget being federal dollars, mainly because of good friends at the Capitol, like Chairman Creekmore, who serves on appropriations in the House, and Senator Bryan, who is always happy to speak on our behalf, that we have seen an increase in our state funding, especially of our public health programs, and that we have worked really hard, as you know, to generate revenue better ourselves and to reduce our overhead. And the county health department reorganization model has been very successful. Had we not undertaken that, I think we would be in grave danger right now with Dr. Dotson and her team's work. And reorganizing the county health department system into something that's more meaningful and robust and cost effective and sustainable is paying huge dividends for us. We have been working off the COVID funds well before, they were rescinded. Reflecting on that, had we not gotten the county health departments off the COVID funding, that was $10 million a year that we had to get them on more sustainable funding without those federal funds. And we had done that before the rescissions. So that helped us get through that challenge without it being catastrophic. So, I'm confident we'll move through the federal funding challenges. I'm not confident of what that will look like this time next year, but I know it will look differently, and I know that we will be meeting with you this time next July, and we will be reporting successes as we always do, and we will be reporting challenges as we always do. Local funding is becoming an increasing challenge for us. County budgets are under the strain as everybody else is, and I wish we had the system that other states have, that public health is built into the millage of the counties, but it's not. Mental health is built into the millage, but public health is not. So it's up to us to continue to be relevant to those county boards of supervisors and to continue to be worthy of their funding, and that's extremely important to me. And then we continue looking at the population health challenges that are before us that we have been talking about the last 3 years, but change can't wait. And now I'm happy to report that change has not waited, and that change is coming. It's coming methodically, slowly, but it's coming. And I included in your packet the last year's Commonwealth Fund report, which is one of the population health scorecards that I monitor very closely. And it has the breakdown of all the metrics that were scored upon, and and where we scored. Disappointing that we still came out 51st. They count DC in that, although I don't think that's fair. But if you remember 3 years ago, I was telling you that we really weren't 51st. We were more like 60th. And that the only reason we weren't 60th was there was no one else to get in between us. Now I would say we have closed that gap significantly. And I would say that because we outperformed every other state with metric improvements. So we had 19 quality metrics that we scored as improved, and that was more than any other state. There were 4 or 5 that scored at 18, but 19 was a substantial number, and that is a win for all of us, our decision makers at the Capitol, our other sisters and sister agencies and state government, our community partners, our nonprofit partners, our faith partners, and certainly this agency and this board's work. The last 3 years, we have objective evidence that the needle is moving in the right direction. So it's the first time I've been proud of being 51st. But I'm just happy that we have closed that gap. And I can tell you, I just returned from a meeting of state health officers in Region 4 and Region 6, and they're all getting nervous because they see us coming. So, I've got my eyes on Oklahoma and West Virginia, and I'm convinced that we will, if we, as chairman, if we will take the same attitude for the health of the population of the state that we have in the education of our children, we will see these population health outcomes improve. At the meeting that I was at, I challenged them, my colleagues, and because they were all saying the same thing. Well, we are where we are. It's just the way it is. I pushed back and I said, where do you think we in Mississippi are in education? And they all said 49th, 50th. I said, how about 16th? In the latest kids count report. And I got fact checked. And they apologized, but but it's correct. And who would have imagined 30 years ago that we would be 16th in education? And we're 16th in education because of investment at the state level and adoption of policies that are working. And I am convinced the same is true of health, and that the health of our population can and will improve as we make appropriate investments in the population's health, and that we value public health and what we do for the citizens of Mississippi, touching every life every day, and how important it is, everything that we do. And it's important enough that is in state law, the responsibilities of this board and of my office. And one of the main responsibilities is to improve the health of the population of the state. And I have been, as chairman will tell you, I've been preaching that at the Capitol, and that awareness has been increasing. And I'm very proud that we are getting more support than we have in quite a while in our appropriation. And at the Capitol, as I shared with y'all last meeting, going 8 for 8 with our legislative agenda, was no small thing, and comes from a lot of work for all of us. As we look at success, I'm going to ask Dr. Dotson, our state epidemiologist, also the director for the Center for Public Health Transformation, to come and give y'all an epidemiologic update, so you see what many of the challenges are that we're up against, and some of the solutions that Dr. Dotson and her great team are leveraging for us. So Dr. Dotson, go ahead.
Good morning. Thank you. As Dr. Edney has modified his prayer for the crisis to come before 3 p.m., those of us who are left after 3 p.m. find ourselves praying, Lord, thy will be done. So here we go. It's right. The big story for us here in the state of Mississippi remains the pertussis. Pertussis update. Just a bit of background, nationally and in Mississippi, the reported number of pertussis cases were lower than usual during and immediately following the COVID pandemic. And then we saw an uptick. And so we thought that the reason it was lower than the pandemic was because of the mitigation measures, as such as masking, remote learning, et cetera, that was implemented during the pandemic may have contributed to that lower transmission rates. So then reported cases began to increase in 2024, both nationally and in Mississippi. And then here in Mississippi, the number of pertussis cases reported in 2024 increased to 49 and was comparable to the number of cases reported in 2019, which was 54, but was higher than the cases in 2023, which were 3. And now the current Mississippi 2025 trends show a continued increase in the number of reported cases. Right. So this is more graphic representation of what I just said to you. As you can see, we had a dip down in 2021, and then we're taking sort of a sharp upturn. As of July 2nd, we've had a total of 71 pertussis cases that have been reported in 2025, and we had a total of 49 last year. And as you can see, this is a little more granular. It shows you the fluctuation by months, but overall, you can see that if you were to draw a line through that, a regression line through that, you'd see that the slope of that line was increasing. When we look at it, the pertussis cases with reference to vaccination status, you'll see that of the 71 cases, 54 of those were in people who were 18 years old and 18 years or younger. 35 cases were not vaccinated, and 30 of the unvaccinated cases were in those individuals who were less than 18 years old. And then the majority, this is just showing the pertussis cases by public health districts. The majority of the 2025 cases have occurred in public health districts 2, 7, and 9. As you can see that 2 is leading the way by far. District 2 really accounts for 39% of our reported cases.
Dr. Dotson, remind them where those districts are.
District 2 is up in northeast Mississippi. And District 9 is on the coast. And District 7 is southwest.
Yeah.
Yay, the Delta's not in that.
So are those high variances due to lack of vaccination?
Yes, the majority of those cases were not, were unvaccinated, in the unvaccinated. So I'd like,
Before we go on, I just, I have maybe a question related to those under 18, because I know just last month, I was in Northeast Mississippi, I saw an infant that was too young to have been vaccinated with pertussis. Obviously, I think the problem is still that there's inadequate immunization by the people the infant was around probably, but I don't know, I don't know of any other way you can protect someone that young. And I guess what I'm saying is under 18 is part of the story, but when you have an infant that's like 6 weeks old or something, you're not gonna have somebody that can even be vaccinated.
and the infant probably was exposed to someone else who was unvaccinated.
Exactly.
That gave it to, so the herd immunity is dropping.
Yeah.
For a number of reasons.
Dr. Carlton, and that's why, we encourage, especially first-time grandparents to get their DPT booster done. When I was in internal medicine practice, I call it the grandparent shot, because the immunity will wane. And we do see pertussis in adults, as well.
How much of a campaign do we have to push for re-vaccination? Because most people probably have the impression that they get their DPTs as a child, and they're done. Is that something that we need to push for, or?
Primary care providers, do a good job as, when it's time for a tetanus booster, if they see if they need diphtheria and pertussis, as well. And, the issue with pertussis in adults, it's just not as scary as in infants because of the airway size. It's the babies that really worry us. But, I think we do need increased uptake because we have a low uptake of flu and pneumococcal vaccination over 65. And certainly we have a low booster rate for pertussis, but it is important that grandparents who are more likely to have had waning immunity get that booster, that they have a newborn being planned to be born in their families.
Strategy for those newborn in the, 6 weeks or first few months is vaccination of during pregnancy. It's, to bridge that gap between the time of birth and then when they can actually get their vaccination.
And I want to brag on, the whole epi team, although we've had these increased number of cases and we've had at least one small outbreak, everything's been, quickly contained and really good cooperation with communities, just working together to get those case contacts worked, get prophylaxis in place. And we've, also had no deaths, thankfully.
Epi said, having district epi nurses that are within the regions and have close relationships with the patients that we serve, the populations that we serve, has been a tremendous asset for us.
Yeah, it's interesting. The grandparent shot is interesting because I've heard a lot of talk about RSV, right? Like encouraging grandparents to get RSV, but you don't hear pertussis as much. It's almost like they need the suite of, you need your DPT booster, you need RSV vaccine, you need your pneumococcal vaccine. It's almost like you're kind of restarting all of the things that you need because the baby's so little, to your point, you got to protect them from all of the things. It's almost like you could do like a campaign of all of the respiratory type viruses, somehow, convince them somehow.
Noted. Thank you. I am happy to say that all of the information that I just presented about pertussis is readily available to any of you from our MSDH data dashboard. Our data dashboard is public facing on our website. Reportable epidemiology and STD HIV data from 2015 to current is available to the end user. You can select which disease that you want to narrow your search on, as well as narrow the parameters. You can search by geographic location, age, race, and time. The data can easily be exported to Excel, so you can create your own reports. It's updated monthly. It replaces our static monthly PDF report that we put out, and so you can get up to date data at any time or at any time that you need. And the website is there, healthymississippi.com page. You just log on to that site, and this is the landing page. When you get to this landing page, it's the Mississippi Morbidity Report. And so here you'll see that you can analyze morbidity trends over time, examining the incidence and prevalence of various reportable diseases. It is of note that the statistics for 2024 and 25 are provisional because we can't have this kind of data without our partners. And so it depends on when data is reported to us and how we can incorporate that data into this dashboard. But because of that, that's what makes this tool so much more exciting for us, because as we get the information that is updated here, you can get it as well. So the report here, this is the report generator, and it allows you to tailor your report for the data that you need. You can tailor it again by year, age group, sex, race, ethnicity, and or public health district. You can create your own little public health heat map if you like. Also, on this page, it shows more of the demographics, how you can sort out the demographics and create different types of graphs and charts for yourself. And also, you can do it by public health district. Here, just by selecting the district. It is of note that if you ever see a star, there are stars in certain places, that's because the number of cases is less than 5. And sometimes, because the cases are so small and communities can be small, it may be easy to, you may be able to reverse identify someone with case studies less than 5. So we do that for privacy reasons. This is the incidence rate and geographic location, so it creates the heat map for you if you so desire to do it by that. And I am very, also we have a page of definitions and explanations that help you better navigate the tool. It explains incidence rates, reportable conditions to help make it more easy for you to understand your report as generated. And I'm happy to say that this data dashboard was created by our epidemiologist in our department, Helena Rowe. And Helena has just been accepted in the master's program at the School of Population Health at UMC.
Lena, please stand. Where are you? Good job. But you're not going to work for the School of Population Health. Okay, let's check.
No, I've got to look back on her.
Thank you, Helena. Well done.
So, I wanted to give you also an update on the syphilis initiatives that we had. So historically, Mississippi has reported some of the highest rates of syphilis nationally. And according to the most recent studies, Mississippi has the 3rd highest rate of genital syphilis and the 3rd highest rate of primary and secondary syphilis. So South Dakota and New Mexico beat us out. We're not upset about that. For the syphilis cases, you can see here, this map puts all of the cases together. You can see each type of syphilis cases there are. The green represents I'm sorry, the teal blue represents primary and secondary syphilis. The green is early latent. The purple is late latent, and the congenital syphilis is that dark blue across the bottom. Now, it looks like in 2020 that just everything broke loose and late latent syphilis became rip-roaring. It did increase, however, but not by the dramatic increase that's demonstrated on this slide. It's because all of the case definitions, several different case definitions for late latent syphilis were all dumped into one category. So that made the numbers rise precipitously, but it's not that sharp of an incline of the curve. In 2024, there were 691 cases of primary and secondary syphilis that was reported. And then from January to June of 2025, we are at 247 cases reported. So it's looking, the data is looking pretty favorable now, because even at the halfway point, we're still trending down. Our numbers seem to be less thus far. These are provisional numbers, but for the most part, they are looking as if we're hitting the mark and making a dent in it. Of course, our African-American males still are the highest group that we see it in, and then African-American females fall the second group at 148. Early latent syphilis cases reported from 24 to 25. There were 378 cases of early latent syphilis. And then from January to June now, we've had 136 cases that were reported. And again, it looks like we are still trending, the number is still trending downward, and we're hoping that that holds as we get to the end of the year. Again, the African-American male population is most affected at 220, and the female population at 148. And then white females are slightly higher than white males in this for late latent syphilis. In the late latent syphilis cases, there were in 2024, there were 1,818 cases, and then trending now from January to June, we're at 547. So at the halfway mark, we're still about 1/3 of where we were. We definitely are hoping that those trends hold. Again, the African-American male community is most effective at 890, with the female population fairly closely behind at 738. And white females, again, are outpace white males with late syphilis. Congenital syphilis, in 2024, there were 116 cases. Thus far, we're at 35 for January to June. So looking at a significant decrease there. And we are, as I said, are hoping that these numbers hold throughout the end of the year. And you can see the districts where most of the public health districts where we're seeing congenital syphilis the most is in District 5, which is the Jackson metro area, and then District 8, which is down on the coast, Harrison Forest, District 8 and 9. And then District 1 is up in the northern part of the state around DeSoto County and that area. And these were also areas that we identified as syphilis hotspots and have been doing extra measures there to counteract the syphilis and HIV in those areas.
So I would remind y'all, about 18 months ago, I appointed the syphilis task force within the agency of pooling programs together, basically all hands on deck to work on syphilis, especially congenital syphilis. And now Dr. Dotson is chairing the task force. A couple of things that have demonstrated objective evidence of success out of the task force's work is partnering with providers around the state, especially in the hotspot counties, to improve screening rates and link treatment to testing. And instead of the old paradigm of, well, refer the RPR to the health department, we'll work it up and we'll find them and try to get them to the health department. That model was not working. But connecting testing and treatment much more closely. And one way was having agreements in place with providers where we would provide bicillin and testing support, if they were serving vulnerable populations with a significant positivity rate, because it's too expensive for clinicians to buy in stock. So, we're serving as a payer of last resort in that situation. And then at South Central Regional Medical Center in Laurel, Jones County being a really important county in this fight, partnered with us to do almost universal screening in the emergency department, just looking at the whole population of Jones County coming through the ER and testing and then treating immediately, and then us serving as a payer of last resort if it was uninsured or insurance wasn't covering the bicillin for whatever reason. And just got the report of that pilot project, and they're running a positivity rate just under 4%. And these are all asymptomatic folks. Just folks coming through the ER, about 4% had active syphilis, and they were able to treat in the emergency department. And so all of those cases that have been identified had been treated, and that has taken that population out of the syphilis pool for Jones County.
Contact follow-up with once it's tested
And
positive.
then, then they report to us, and we do our normal disease investigation evaluations. And then the other program that I'm real proud of that came out of the task force, I call it the SHOTS program, Dr. Dotson, where this is following Louisiana's model of providing a public health nurse to a DIS worker, the disease investigation specialist, who go out and work the cases, and sending a public health nurse with them. So when we identify the case, we identify these treatment, we just go ahead and treat instead of trying to get them to the health department. We just send the nurse out with them and because we were scoring pretty well with testing, but not scoring well with treatment. So we're closing that loop as much as we can. And there's no doubt the emergency order that I did and y'all validated 2 years ago has really impacted congenital syphilis. That mandated testing 3 times during pregnancy, twice during pregnancy, and once right after birth has really helped. And I was so proud to see those 2024 numbers. I mean, seeing those congenital syphilis cases finally come down is huge. And then seeing that forecasting for this year, very, very strong. So, Mr. Chairman, we were able to do all this work with that extra funding that y'all provided for us for public health programs, and you allowed us the discretion. We have been leveraging that funding in the syphilis work heavily. And I'm really proud to see the results that the team is demonstrating in partnership with our community partners. And so next, seeing the success in Jones County, we know UMC is doing likewise in their hospital ER system. And now looking at other hotspot counties and partnering with their hospitals to do likewise in their emergency departments, where payer of last resort, if they'll do the screening, we'll make sure that they don't lose any money on it. And so Hines County, we do need another partner in Hines County. Dr. Carlton, Pat Cheney up in Northeast Mississippi, we need to partner up there. Talking to the partnerships we have in Harrison County, which is another important county. So now that we're demonstrating success, and we thought we would see this, but proving what we're seeing now, I think it's time to not scale it statewide, but go after the most impacted counties.
One of the primary reasons I asked about contact tracing was simply from the emergency department. It is so difficult to do. You have false addresses, false phone numbers, or other people that are checking in, much less contacts. And so I assume the Department of Health, the local
Yeah, so it's still, even though they're being treated, there's still a duty to report the case. Because we had to report the contact. So it is one of those, syphilis is a 1A. It's congenital syphilis and pregnancy is a 1A, but it's a high level reportable case. And then we'll do our normal contact tracing after that.
These are the 1As.
I feel like 20 years ago when I got married, in order to get my marriage license, I had to get a syphilis test.
Right.
Is that still a thing? Okay. Because I remember thinking it was like, you have to get tested for syphilis, but not HIV. And I remember back then thinking, that's interesting. And so now you don't have to test for any.
But Griffin, you're telling your age now.
That's all right. Mom. Okay. I just wondered if that was still a thing. I obviously haven't tried to get married
That was a-
lately, so.
It was a requirement in state law that's been repealed. I wish they'd put it back.
Yeah, that.
Dr. Dodson, before you leave, any questions for Dr. Dodson, who gave an excellent report? We appreciate your great work. I do think the board, though, clearly was seeing a need for a louder campaign perhaps on pertussis, because I think the general population is not aware of the dangers posed by that. And if we could think of some press releases and other communication to the general public with pertussis, that would be very good.
Thank you.
Thank you, Dr. Dodson. And as we look at successes from the year, I'm very pleased to let you know that we just finished the 25 state fiscal year in a healthy fashion, really working hard on stewardship of our state resources and keeping overhead as low as we can and preparing ourselves as we move into the next federal budget year to see how those cuts are going to look. But we finished the state budget year in good shape. And right now we are preparing for about a 30% cut in federal funding. We just don't know yet how that, how that's going to look. We know with the president's proposed budget, so it gives us a roadmap of where HHS is really looking at cutting. And it's interesting. Some areas are receiving increased funding. A lot of level funding, but then significant cuts to areas that are really important to our work. So we're monitoring that very closely, and I will keep you apprised as we know more. Other significant wins that we have had, and I have to remind myself, we deal with challenges every day here, but I have to remind myself of the wins as they come. I was real proud. I think we had 3 academic publications in the last quarter, peer reviewed, 1 manuscript that I know of. And that's just shows you the caliber of the work that goes on and the different types of work. Bill Moody, would you stand? Bill is part of our water team, and Les, his boss, but Les has a lot of environmental responsibilities, and Bill is one of our water experts and does a good job helping keep all the water systems with the technical assistance they need. But I was so proud to find out that Bill received the George Warren Fuller Award at the National American Water Works Association Conference, recognized for service in the water supply field, commemoration of engineering skills, diplomacy, and leadership skills exemplified by the award's namesake. And it's always wonderful when we have program managers who are receiving national recognition. So Bill, congratulations, buddy. And Lauren, with our Director of Communication, where are you? Okay. So this is not mine. This is Lauren and her team's. This is an award that Lauren and the team have received called the Tilly Award. Lauren, you're gonna have to explain what the Tilly Award is. I'm proud you got it. I'm not sure what it is.
No, this is a nationally recognized award in the marketing sector. So we work closely with our tobacco team for the youth vaping campaign, where we strategically targeted our youth by using their common vernacular to discourage vaping. So 13,000 submissions and we won bronze.
Outstanding. I'm so proud. Thank you. Anybody else from comms?
Greg's right.
And Greg does media relations for us. Greg also is the host of our new podcast that Lauren and the team have developed. you'll have to get past the first episode and not worry about that too much. I'm sure the uptake will improve as you get better guests. You know, but the podcast is very well done and really pleased with the production product. I hope y'all can see what I see, that our communication efforts are really at a much higher level than certainly I have seen. Everything they do is with excellence and very professional, and working to maintain good working relationships with our media partners, communicating well externally and internally. And just so proud to see y'all's work recognized. Lauren.
I was going to comment on the podcast. That was so well done this week on Monday. We got a real natural here, and Dr. Idney for that. And it's going to be the first Monday of every month, right? And you can get it in all kinds.
Lauren, you want to give information about
Yes,
how
sir. It will be
access?
it will be the first Monday of every month. And we will have various subject matter experts talking on different topics and subjects. And we're in partnership with MPB. They've been a great partner. So we're able to go there and record the podcast, and they help us push it out.
We need to do one on Pertussis.
And I mean, you can get it on all the normal platforms. I know I've downloaded it on the Apple platform. So
What's the name of it?
Health Talk.
Health Talk.
Talk MS. And I had teased y'all a little bit about this next recognition, and we have with us today our Vital Records team, and Pat Alwadi, who's our new registrar that y'all approved at the last meeting. And with Pat today, we have Trandy Atkinson and Kiana Terry. Would y'all stand? And I know Trandy, you were team lead, I believe, but it was a team effort, and including Judy Mulder, who retired. God bless us. She retired last month, but in this, they have officially received FAB accreditation for our Vital Records program. We're only number 6 in the country, y'all. And so we are dually accredited as a public health state Department of Health, but also our specific vital records work. They did this voluntarily. This was not mandated of them to do. They wanted to demonstrate excellence in their area, which they didn't have to prove anything to me. You know, I know how excellent their work is. But you know, as I get calls about death certificates, you know, I'm able to quickly point out, but I can promise you, once it gets in their capable hands, it's turned around quickly, but there's a lot of things holding it up, getting to them. But to have the objective evidence that we shared with y'all at the last meeting, what the turnaround times are and how good their work product is and how well respected, you know, they are certainly within the agency and by myself. But, you know, they are demonstrating respect and recognition of nationally accrediting bodies. I want to thank y'all so much for the good work. Congratulations. All right, and then
Before we go to the legislative update, are there any questions for Dr. Edney about the Commonwealth Fund rankings or you did note that he says he's only 3 years into his term, so his 6-year term. Just making sure.
He's saying he's halfway through. I think it's like 1% through.
Here for a little while.
then, Mr. Chairman, as we had discussed, we're going to do a quick in-servicing of our new product, OpenGov, that has to do with compliance issues related, especially with all of our funding, all of our sub-grant awards, and most particularly our federal funding, where we're awarding contracts and sub-grants out, to show you how we have already stepped up our game to work to eliminate all fraud, waste, and abuse as much as we possibly can and be compliant with state law and federal law rules and regulations. So Wayne is going to do a quick review of the power of this product so that you know what we're working on.
Yeah, this will be pretty quick, and I'm by no means the expert when it comes to this topic. Dorothy owns the expert, but we let her take off this week. So enhancing procurement with OpenGov is really just modernizing our procurement processes, increases transparency, efficiency, and just overall impact. All right, so why modernize procurement? We had a very outdated system that was aiding our efforts in procurement. Lots of inefficiencies, delays, errors with the old system and process. There's always an increased need for transparency in government, taxpayer money, right? Need for real-time data, accountability, compliance, opportunity to align spending with strategic goals. Improve transparency, accountability. You got online access to solicitations and awards. So you can actually go to our website. We got screenshots later. Couple clicks away, I've seen what vendors could easily throw their hat in the ring for. We also have like executed agreements from this process as well. The real-time status tracking for internal, external stakeholders, easy to publish data, one version of truth across all departments. So everybody's using this in our agency. The templates include IFBs, RFPs, RFQs. So that's requests for proposals, requests for quotes. There's a lot of different things, and this is all like PPRB type stuff. So it's the process flow from DFA that's incorporated throughout OpenGov. Automated reminders, deadline for tracking. The old process, you didn't have stuff like this. So you have reminders going out to program areas. Hey, maybe got a contract that's about to end. You might want to be thinking about how you want to procure for that coming up if you need to. Real-time collaboration across program staff, finance, and legal, just making sure we got all the parties involved that need to be involved in these agreements. Reduction in procurement cycle times. So vendor experience. You have the central portal, less confusing. So it's again that one-stop shop. Self-service registration and submission for responses. So the system will actually communicate with those vendors that are applying for things, let them know what their status is in the process and anything that we may need additional notifications for relevant procurements, reduction in the barriers. Because again, it's the one system. Everybody gets to use it. Real-time analytics and reporting, tracking the spending by category, vendor and/or department. So this is really one of the big pluses we had with the old system. Old system, you couldn't get like a data dump of all the information from it. You couldn't really run analytics to see like what some of the vendors may have been, if we had maybe cross vendors that could have done other things possibly, things like that. So we got a lot of cool things that we can do with this new system, including the identification of bottlenecks and trends, could include KPIs, integration with finance, to sync budget data, facilities paying for performance. So this is the exact detail. We go to our main page on our website, landing page, menu, procurements, RFPs, and then you're prompted with this screenshot on your right, what the portal looks like. So if you were to visit the portal here with this blue button, this is what you would see. You would see the various projects that we have that they're open. And again, this is where vendors could throw their hat in the ring for something like this. Super easy for vendors to sign up on as far as the email address, and then they have to do some stuff with DFA, of course, registering. You also have like the completed procurements. We provide the listing out there as well. Again, this is all just part of transparency, right? Making sure that everybody knows what we're doing, what we have out there as proposals, and then the executed agreements that come from them. Anyway, but, didn't bore you too bad with, some administrative stuff for the agency.
Before you run away, let's see if there's any questions. Any board members have any questions?
So this is a tool that will really facilitate Wayne and his work with, helping us remain compliant and as we want to be. It's a much more powerful tool. It really just brings us into the 21st century with our procurement work and with, the size of our budget, the scope of our work. This is helping us a great deal. For me, a big part of the analytics that we just have not had. And now to be able, to get granular on where funding is going and, but definitely transparency from our part to vendors to make sure that we don't have a vendor in 3 different program areas, doing similar work. And it also vets our vendors and our partners much better than the old system, which didn't vet it much at all. So I'm a real fan of this, and it already has greatly improved our procurement work. I feel much, much better about where we're moving things.
Wayne, from our responsibility as a board of fiduciary responsibility, this is going to ensure better accountability and reduction of fraud, correct?
Absolutely, absolutely. All that. Every year, my team in internal audit, we do an annual review of agreements, contracts are a part of that. And my team's like kind of very giddy and excited about leveraging a system like that and the other things what we can do with it when it comes to adding audit procedures for that very purpose.
Is it used by other departments within the state?
Go ahead, Chris.
Yes, we've got other departments that are interested in looking at it, and also DFA is taking a tour.
We're the first to adopt it though.
We are.
So, but everybody's seeing the success that we're demonstrating. And the fact that DFA is looking at it, says a lot.
There are other states, other bodies that leverage the system, one of the more highly leveraged systems. State and government.
We have about 1,100 vendors currently registered, so they definitely are looking.
All right, any other questions for Wayne? Thank you, Wayne. Appreciate you.
That is all, Mr. Chairman.
Excellent report. We look forward to several more years, many more years of reports. All right, who's next? Our Chief Financial Officer?
Yes, sir. Our legislative report basically is our appropriation. We did the legislative report last time on the general bills, and since then, we've had the general session that handled the budget. And y'all met Mr. Bune, who at the last meeting, she now is officially our Chief Financial Officer, and Lucreta's going to walk us through quickly how the appropriation looks and show you some comparisons.
I'm sorry, but the slides were not included, but to give you all a snapshot, our House Bill 19 is what gave us our appropriations this year, and pretty much we are at level funding. Our public health appropriation, general funds, again, around level, we're around 61 million in general and 530 million in special fund. We're thankful that we still have what we need to continue to operate. Just a couple of high points, the trauma state source funds still remain at 34 million, again, level funding. Our medical cannabis is also at level funding, right under 8 million, 7.6 billion. Also another area, our other bucket, local government, rural water is also around level funding, around 176 million. We will be using, as Dr. Edney mentioned, this time of the year, especially coming in, we are evaluating and doing a deep dive of our budgets and of our spending, and we'll be able to share more in October's budget meeting, how we fared for the end of the fiscal year. But as far as appropriation goes, we are at level fund. If there are, any specific questions, regarding, any specific item, please let me know. And I can try to address them now if y'all have.
Construction projects, how are they going?
Okay,
Is that coming up?
yes, we have actually several going on now. If you, once you get a chance, leaving out of the meeting today, if you will walk out that door, you can see the progress that's being made on the pharmacy warehouse that's being funded by ARPA funds. It's, I want to say since you all were here in July, it's much more, not July, April, is much more progress right now. The estimated date is, it was October. We have a meeting actually today with DFA to discuss more of the progress. Additional projects we have going on. We will be getting started on the Central Complex Garage Elevator Project. It is moving forward. I think maybe you all have heard of that on a different occasion, but we are proceeding with that along with DFA funds are there. So we're moving with that. In this building, the Osborne building, I'm sure you saw the cranes out front. We're getting ready to get started with the Osborne envelope project, where they've already done work on the roof. So hopefully the roof is good now. And we will be doing the envelope, which will be the, not to get too technical, removing the bricks, fixing some deficiencies within the wall. And also the same type of project will be going on at the lab next door. So we have several projects that have been on the books that they are beginning to roll now. So it's going to be a lot of work going on in campus. We did have one request that we put in for the upcoming our wish list, so to speak, for the Osborne building. We need to work on our elevator. So that's another thing that will be coming up.
All right, excellent. What questions do we have? Any board members have any questions? We appreciate your good work.
Thank you.
And that was pretty much the result of most agencies were level funded. And I was more than okay with that, I was grateful that they maintained the special appropriation for public health programs and that and helped us with some of the early intervention funding. So it's, even though level funding is a cut, just because inflationary cost, our PERS obligations and our state health insurance plan obligations go up significantly. Those weren't covered. We'll be okay. And kind of, I'll tell you, my MO is to be low maintenance, and I had a lot of feedback that they were grateful of our attitude through the budget process. So I plan to continue that.
And your definition of low maintenance is what, lean?
Staying off the radar as much as possible. It's, just asking for what we need and knowing that we're in budgetary times that, if we're over asking, that's not helpful. So when I ask for something and can demonstrate why we need it, it's received better than just every year going and asking for another 30 million, another 30 million. Also we had opportunities ourselves. We have a responsibility to support ourselves as much as we can. And we've been really developing that the last 3 years and showing success.
Very good. All right, ready for the regulatory agenda? Thank you, Dr. Edney, and we're now on the board regulatory agenda, which is actually a consent agenda, which consent means no drama to it, and we should be able to approve both items. The two items, the first one is an amendment to regulations concerning registration of individuals performing hair braiding, and this is just a regulation cleanup for formatting and clarification. The other consent agenda item is appointment of two individuals to the Child Care Advisory Council. Two new members are proposed, Michelle Rittenhouse and Matthew Williams, and these are proposed by respective organizations. So unless one of the board members wants to extract those items for further discussion, I'll entertain a motion to approve the consent agenda, which is both of those items 1 and 2.
Motion to approve both.
All right, there's a motion to approve the consent agenda. Is there a
I,
second?
I second.
Excellent. And any further discussion about the consent agenda? If not, all in favor, say aye. Excellent. All right, we're moving along. Committee reports. Maternal Health Committee, our very important committee. Dr. Cheney, give us an update about how we're doing.
Well, certainly exciting. We had the kickoff meeting for the OB system of care in May, and it was very well received. I think that's evidence of that people are really buying into the need, and I thought that meeting went very well. And I would see that there's going to be obviously a significant amount of work for the maternal infant health subcommittee, and I think that's going to revolve around what we will do to support the system of care process.
Excellent, excellent. Any questions?
And also Dr. Cheney, we had presentation from Dr. Henderson related to infant mortality. And basically working with the committee, we've looked at all the recommendations from Dr. Henderson's Child Death Review Committee. And I've enacted everything that's within our authority to do. And one really specific area is really focusing on infant mortality as a standalone death review instead of being part of child death review, and having its own independent mortality review committee looking specifically at those deaths 0 to 12 months. And it's so helpful for us to be able to present that information to the respective committees of the board and get the feedback from those board members. So we're moving along with our femur work, the fetal infant mortality work, the now specific infant mortality review, and the maternal mortality review as we've been doing. And understanding that our mortality review work is where everything begins. I mean, that vital records starts it. We have to look at the vital records data from our death certificates immediately, and then they go through the mortality review process where we convert data into information, and that's where we're able to answer questions. We're going to get an infant mortality report that that I'm not very happy with, but I can't tell you why until we do the mortality review. Then the mortality review gives us answers, and then we can act on that. So the mortality review takes longer. It's always a couple of years behind just by the nature of the process, but the provisional data we get from vital records combined with mortality review is really where we're able to get thoughtful strategy. And OB system of care is coming out of both maternal and infant mortality review work.
All right, good work. Keep it up.
I'd like to add to Dr. Cheney, I really thought that was a great kickoff that we had. I was super impressed at how many agencies and hospitals and other physicians and all that are behind us on this and supporting us and helping us with all the data and making it happen. So very, very important. Thank you, Dr. Cheney.
And Dr. Brooks, stand up. Let me introduce y'all to Dr. Tammy Brooks, who is our new permanent agency medical director. And she has graciously agreed to spearhead a lot of the coordination of our mortality review work to help it administratively perform at the level that it needs to, and then making sure that our volunteer reviewers like Dr. Henderson and members of Child Death Review Committee, are being supported in the way that they need to be. And in October, we'll we'll be talking to Dr. Cheney's committee about adding to next year's legislative agenda some issues specifically looking at infant mortality review that we've been considering the last few years that we need to vet through Dr. Cheney's committee. I think we're getting close.
And Dr. Brooks is such a great addition to our leadership core. Just truly outstanding, truly respected around the state for her work. So thank you for coming to work for us.
Well, I thank you, I'm honored. It's a lot of the work that we're all doing.
There's a lot of work to
Do
do.
it, yeah.
And you love your boss, don't you?
And I have the best boss. Still very.
All right, anything else with maternal health? The CON committee, Chairman Creekmore, Chairman Bryan asked the CON committee to do a deep dive into some CON reform. We're taking that request very seriously. We've scheduled 2, probably 3 meetings to explore such issues as dialysis and other potential areas of reform, especially reform that may benefit the rural hospitals of our state. We're looking forward to partnering with Chairman Creekmore and Chairman Bryan and trying to find some positive benefits for Mississippi citizens, but that'll happen probably over the next 3 months. And we hope to bring to the October meeting some finalized ideas for the entire board to consider. As far as the audit committee did meet. We'll probably talk about their discussions in executive session. Nothing more from the committees. New business. Mr. Moody retired. It was a very valued and appreciative member of this board. We have discussed creating a resolution of thanks for all of his contributions. We have not prepared it yet, but what I wanted was that this board to approve a resolution of thanks for Mr. Moody and to let our staff prepare it for presentation to him. Can I have a motion to approve a resolution of appreciation for Mr. Moody? Second. The motion and a second. Is there any further discussion? And y'all will see it. It will be sent around. All in favor, say aye.
Aye.
All right. All right. It's your floor.
Thank you, Mr. Chairman. Senator Bryan had planned to be here, but I'm glad that Chairman Creekmore is here. Both are very well deserving of this honor. Our Healthy Mississippi conference that we had last month was a huge success. And this is where we invite our community partners, community organizations to come together, and it's a time of professional development, but also a time that we're able to present to our community partners, what's going on. Many of the things that we talk about here. One of the things that the program area that sponsors that does is recognizes our public health champions each year. And this year, the award went to both Chairman Creekmore and Chairman Bryan, who are the respective chairs of our public health committees in the House and the Senate. They both were at out-of-state conferences, were trying to work their way back to receive the presentation at the conferences. Said, no, don't. We'll do this at Board of Health. But we appreciated y'all wanting to be with us. I want to extend appreciation for contributions to protect and advance the health, well-being, and safety of everyone in Mississippi. And with both of y'all, you never have exceptions to that. I want to give my personal thanks. Our relationship doesn't just go on during the session. We're calling each other, both committee chairs are in contact with me through the year. I appreciate the advice and counsel they give me. I very much appreciate the fact that they reach out asking our advice, oftentimes on bills that have nothing to do, with our legislative agenda, but they want to know what we think. I'm very grateful for that. We would not have gone 8 for 8, Logan, the last session if it weren't for these 2 men who personally got our legislation through. And they knew, but they understood what we were asking for and why we needed it, why we were asking for it. And they were very gracious to make sure. And two of the bills that they helped shepherd through are gonna help us get through these federal cuts. Yeah, it will. And so I'm very, very grateful. But please allow me to recognize Chairman Pete Moore. I'll make sure Chairman Brian gets his as quickly as possible. But y'all join me in thanking Senator.
All right, please.
Board. Number one, truly an honor. I think world board, things men and women who I respect great. But we recognize all humble, great. Thank you. Number two, I only see this. It said, I share the same vision. Dr. talked about. It's, get us off the bottom. This only incentivizes me to do more work. And number three, y'all ever wonder why it's so hard to get stuff done in the legislature? Today's a perfect example. Only half the legislature showed up, the other half was no-shows. Anyway, y'all experienced my pain. No, truly, I love Senator Bryan, but thank y'all so much.
Thank you. Thank you. Your leadership is very much appreciated, but your presence here really reveals a lot about the engagement of your leadership this way, and it's noted. Thank you. All right. Is there any old business that the board would like to bring up? And I guess I should have asked new business too, no new business. All right, we do have a need for an executive session based on pending litigation. So I need a motion to go into executive session regarding a litigation matter. There's a motion.
I so move.
All right, we're going to go in executive session. You're back? Yeah. All right, we return to regular session. As far as executive session, there were the board discussed pending litigation and no actions were taken. Our next board meeting dates are October 8th, January 7th, and April 8th. The October 8th meeting may be a strategic planning session. And the meeting may be at 1 instead of 10, but that is in the works. Members, please remember your gift on the table. Lunch is upstairs with staff. That's important to interact with them. And do I have a motion to adjourn? So the deed is done.